Hi, everybody. This is the SPY review on miscellaneous pharmaceuticals. We'll go through a number of agents today, first focusing on anticoagulants, then moving into phosphodiesterase inhibitors, metoclopramide, local anesthetics, and methotrexate. We'll start with anticoagulants. We'll first talk about the clotting cascade. We see here the intrinsic pathway, which is triggered by an internal vessel injury. We then see a sequence of activation of clotting factors. If we move over here to the extrinsic pathway, which is triggered by an external vessel injury, this also follows a series of activation of clotting factors, ultimately culminating into the common pathway, which takes factor 10 to activated factor 10, moving factor 2 to its activated form, thrombin. Thrombin then takes fibrinogen to fibrin, leading to cross-linking and polymerization in a fibrin clot. So first, when we talk about heparin as it relates to the clotting cascade and its function as an anticoagulant, heparin has a variety of indications. We see this used in prophylaxis in hospital settings and in the postoperative setting. We see this for the treatment of acute venous thromboembolism disease, as well as the treatment of acute coronary syndrome. We also see it in the use of maintaining intravascular access, as well as during hemodialysis. There are two different heparin formulations that we should be familiar with: conventional or unfractionated heparin, which will be abbreviated as UFH, and then also low molecular weight heparin, which will be abbreviated as LMWH. Enoxaparin is the most common of our low molecular weight heparins. Heparin here works to bind and activate antithrombin 3, highlighted here in green, which then inhibits activated factor 2 or thrombin. We also have inhibition of factors 9 through 12, as well as calcarein, plasminogen, and protein C inhibitor. In addition to this, the low molecular weight heparins also have great activity at activated factor 10, which you can see here. The toxicity related to heparin is quite variable and is both dose dependent and dependent on individual patient factors. Related to its clinical presentation, we should break this down into an acute exposure and chronic exposure. Related to acute exposure, we see a spectrum of bleeding syndromes. This can result in visceral and subcutaneous hematomas, gastrointestinal hemorrhage, spinal hematomas, and intracranial hemorrhage. In the setting of chronic exposure, we can see necrotic skin lesions, aldosterone suppression, and osteoporosis. Then it's important to be familiar with the entity known as heparin-induced thrombocytopenia, abbreviated as HIT. HIT occurs in patients who are previously exposed to heparin, oftentimes in a hospital setting, and then are readmitted to the hospital, re-exposed to heparin, and quickly develop thrombocytopenia. This is an immune-mediated response that can lead both to thrombosis and bleeding. Treatment is dependent on discontinuation of heparin and then starting an alternative anticoagulant. Diagnosis of heparin is really based on clinical history, as we'll see with all of these exposures. We can obtain specific levels related to heparin toxicity. If we're talking about unfractioned or conventional heparin, we measure the activated partial thromboplastin time. If we're talking about low molecular weight heparins, we can measure an anti-factor 10A level. Additionally, we should know what patients' potassium, their serum creatinine, hemoglobin, and platelet on a CBC, thrombin, fibrinogen levels, and their prothrombin time. Management is dependent on stabilization of shock. Decontamination is not offered to patients, as this is oftentimes a subcutaneous or intravenous exposure, and the agent should be discontinued. Shock should be treated with blood transfusions as needed. An antidote is available for both forms of heparin. It's called protamine sulfate. It has a very rapid onset within minutes and lasts for about 2 hours. This is very often used in the cath lab. Dosing is dependent on the dose of heparin that was administered and then when the last dose was administered as well. There should be caution if patients have a fish allergy, as protamine is derived from fish. Other interventions that can be offered are activated factor 7, as well as tranexamic acid. There's no enhanced elimination for heparin toxicity. We'll now move on to warfarin. So warfarin, we should remember, is associated with wheat clover disease, and this is partially how warfarin was discovered. So in the 1920s, on various farms in northern United States and in Canada, there was an increased incidence of cattle death related to hemorrhage. It was noted that many of these cattle were eating moldy sweet clover. 10 plus years later, coumarin was identified as the source and leading agent for hemorrhage in these cattle. And then in 1948, here in the state of Wisconsin, at the Wisconsin Alumni Research Foundation, warfarin was actually patented as a rodenticide. You can see the clever name warfarin is derived for WARF, the Wisconsin Alumni Research Foundation, and the N from coumarin. We should also be familiar with superwarfarins, which are used as rodenticides, the most common being brodifacoum. And again, the indications here is an anticoagulant, so again, in the setting of venous thromboembolism, and then also as rodenticides. Warfarin's mechanism of action is by inhibition of vitamin K2,3 epoxide reductase, as you can see here. Ultimately, this leads to inhibition of the conversion of vitamin K epoxide to vitamin K quinone, which is needed to carboxylate various factors, those being factors 2, 7, 9, 10, C, and then protein C, S, and Z. Without this carboxylation step, these factors cannot be activated and subsequently do not function in the clotting cascade. Important pharmacodynamics for warfarin, so its half-life is about 40 hours, important pharmacokinetics related to warfarin. We see a half-life of about 40 hours, an onset of 15 hours, peak effect within 2 to 3 days with continuous administration, and a duration of effect of about 5 days. So there is some patient variability with this. When we're talking about superwarfarins, the potency is 100 times that of warfarin, and this leads to both longer onset of action and longer duration. When we're talking about warfarin, it's important to understand if there is a single acute ingestion or if this is a patient who's chronically exposed to warfarin. For single acute ingestions on the order of 10 to 20 milligrams, there's often no problem. These patients can be observed for a short time and then disposed. For chronic repeated ingestions, there is an increased risk of bleeding. And especially when we're talking about superwarfarins, after a single ingestion, there can be life-threatening hemorrhage. Clinical presentation, obviously here is bleeding. We can see ecchymosis, subconjunctival hemorrhage, hemorrhagic gingivitis, internal hemorrhage, and the manifestations of hematemesis, melena, hematochezia, menorrhagia, hematuria, and intracranial hemorrhage. This was in the New England Journal of Medicine in 2019 that documented an outbreak of synthetic cannabinoids that were laced with brodifacoum as superwarfarin, and patients who were presenting to emergency departments around Illinois and into Wisconsin with hematuria, flank pain, found to have retroperitoneal hemorrhages, and some patients suffered intracranial hemorrhages as a result to unintended exposure to brodifacoum. Diagnosis of warfarin toxicity is really dependent on history. Again, most likely there's going to be a known exposure to warfarin, but we can see elevated INR and PT. If patient's INR is normal at 24 hours in the setting of warfarin exposure or normal at 48 hours in the setting of a superwarfarin, there's likely no significant ingestion and there will be no risk of bleeding. Important to also tame a CBC to understand what hemoglobin and platelet levels are, and then a type and screen in anticipation of administering blood projects. Superwarfarin levels can be obtained through commercial labs but have little clinical importance. Management first should start with decontamination by administration of activated charcoal. And then depending on what a patient's INR, if there is bleeding and what the severity of bleeding is, and then what type of warfarin should be ingested, a plan to both stabilize shock and administer blood products or an antidote should be formulated. We're talking about stabilizing hemorrhagic shock. Whole blood products can be transfused as well as fresh frozen plasma. Neurosurgery should be involved if there are any kind of neurological deficits. Obviously, trauma should be avoided, so caution should be taken when inserting any lines, tubes. Fall prevention should be maintained, and then all further doses of warfarin should be held. When we're talking about anecdote administration, some of these aren't truly anecdotes. Vitamin K1 we'll skip here, not vitamin K3, ultimately restores production of those factors. Its onset is about 6 hours, and therefore in the early setting when working to stabilize shock, other products may need to be administered. If we're talking about superwarfarins, we should anticipate that there needs to be prolonged dosing. And then caution really should be taken when we're talking about reversing anticoagulation in the setting of a prosthetic heart valve. Vitamin K dosing is really dependent on the INR of the patient and whether or not there is significant bleeding. Here's a breakdown of INR with or without the presence of bleeding. Oral vitamin K is preferred, though intravenous vitamin K can also be administered for a faster onset. If we move back up here to four-factor prothrombin complexes or four-factor PCC, this contains the factors that are inhibited by warfarin. And then also fresh frozen plasma, which contains higher concentrations of clotting factors that previously would have been inhibited by warfarin. We'll move now into the direct oral anticoagulants or DOACs. These are really the preferred method for anticoagulation now. We see a lot less warfarin. The benefits of these medications is that they are target-specific inhibition. Instead of affecting multiple factors and proteins, we see fewer medication interactions. We see a peak effect in 1 to 4 hours with a much shorter half-life. The 10A inhibitors that we'll discuss most commonly are rivaroxaban, apixaban, and doxaban. These are protein-bound and they are hepatic metabolized. And then we have one thrombin inhibitor, dabigatran. It's important to note that this is 80% renally eliminated. When we talk about the mechanism of action of DOACs, these are 10A inhibitors, which you can see right here. Inhibition of 10A, and so then we don't have activation of factor 2, prothrombin to thrombin, and the formation of a fibrin clot. Or if we're talking about thrombin inhibitors, we have inhibition of thrombin right here. And again, we don't take fibrinogen to fibrin and make an active clot. Similar to warfarin, toxicity related to DOACs is really dependent if this is an acute or a chronic ingestion. So for acute injections, there may be impaired coagulation at a molecular level, though likely there will be limited clinical hemorrhage. In patients who have chronic ingestions, these are more likely to suffer hemorrhage. So clinical presentation is bleeding. This can range from minor to life-threatening. Again, we see ecchymosis, subconjunctival hemorrhage, hemorrhagic gingivitis, internal hemorrhage in the form of hematemesis, melena, hematochezia, menorrhagia, hematermia, and intracranial hemorrhage. It's important to note in patients who have renal failure and are administered dabigatran, it is 80% renally eliminated, and this increases their risk of having catastrophic hemorrhage. Diagnosis, again, is based on history and an exposure to one of these medications. Specific levels can be obtained, but they are probably of limited clinical use. We can look at factor 10A levels, though the calibration for this is somewhat limited. If we find a normal PTT in the setting of dabigatran exposure, this excludes dabigatran toxicity. Conversely, if we see a normal PT in the setting of rivaroxaban activity, though not the other 10As, we can exclude excess rivaroxaban activity. Important to obtain for these patients, as well as a CBC, to look at both the hemoglobin and platelets, type and screen in anticipation of potential blood transfusion, and then serum creatinine. Management here focuses on decontamination with activated charcoal, and then again, similar to our other anticoagulants, is stabilization of shock. For thrombin inhibitors, PCC or prothrombin complex concentration can be administered. For 10A inhibitors, we can provide activated PCC. Fresh frozen plasma can be administered, as well as various blood products. We have 2 anecdotes to be familiar with. The first one is idrizumab, which is an antibody fragment that goes and binds up dabigatran. And then adnexa alpha, which is a recombinant factor 10A that acts as a decoy. And so any of the 10A will actually bind to this agent. Enhanced elimination can be utilized, specifically hemodialysis for dabigatran, but because the other medications are hepatically metabolized and not eliminated by the urine, they have no benefit. We'll now move on to phosphodiesterase inhibitors. So of the phosphodiesterase inhibitors, the ones to be familiar with are sildenafil, tadalafil, vardenafil, and evanafil. Sildenafil and tadalafil being the most common. There are a variety of clinical indications: erectile dysfunction, BPH, and pulmonary hypertension. These medications work to inhibit phosphodiesterase 5, which is right here. And ultimately, this leads to a decrease in the breakdown of cyclic GMP. We see continued activation of protein kinase G and subsequently relaxation of smooth muscular vessels. Toxicity related to this medication overall is really well tolerated. We can see hypotension in the setting of vasodilation, headaches, subsequently flushing, and dizziness. It's important to educate patients on co-administration of nitrates that they may be taking for chest pain as well, that we can have profound hypotension with both these medications are administered. Diagnosis is really based on history. There are no specific levels to obtain. Activated charcoal can be administered. Management is based on stabilizing hypotension. This can be done through postural changes, such as having patients lie supine and raising their legs, or administering isotonic fluids. And there's no indication for enhanced elimination. Next, we'll move to metoclopramide. Metoclopramide has a number of indications, some of which are FDA approved and some of which are not. The FDA approved indications include nausea and emesis and gastroparesis, acid reflux, and nausea and vomiting related to chemotherapy. We also see metoclopramide used for the treatment of migraines, hyperemesis gravidarum, postoperative nausea with emesis. It's important to note that metoclopramide is renally eliminated, and then its mechanism of action really focuses on both antagonism of central and peripheral acting D2 receptors. We also see antagonism at 5-HT3 receptors and agonism at 5-HT4 receptors. And then finally, blocks the antiperistaltic effects. Toxicity is related mostly to the D2 antagonism. So we can see some sedation and diarrhea. More importantly, we see extrapyramidal symptoms, and this can range from acute dystonic reactions, which can manifest as torticollis, trismus, obsitanus, akathisia, dystonia, ocular gyrate crisis, laryngospasm, tardive dyskinesia. We can also see tardive dyskinesia, Parkinsonian features, and then finally, neuroleptic malignant syndrome, which is a combination of encephalopathy, fever, lead pipe rigidity, autonomic instability, and seizures. Somewhat related to its D2 antagonism, we can also see hyperprolactinemia. Diagnosis is based on history. No specific levels are available. Initial decontamination, activated charcoal should be recommended and administered. Management focuses on stopping the offending agent and then providing good supportive care on the method of airway management and fluid resuscitation. No enhanced elimination is recommended. Local anesthetics. Two main indications for the use of local anesthetics. First is for anesthesia. This can be in the form of subcutaneous, mucosal, spinal, or epidural anesthesia. And then we also see local anesthetics used as antidysrhythmics. These agents are categorized by their structure. They can either be categorized as amino esters or aminoamides. These compounds have the same basic structure, either a lipophilic aromatic ring, which you can see here. They then have an intermediate change, and here we see an ester or an amide, and then a hydrophilic tertiary or secondary amine. The ester type are rapidly hydrolyzed by plasma cholinesterase and have a relatively short half-life in comparison to the amide agents, which are hepatically metabolized, have longer duration, and have a higher risk of accumulation and worse toxicity. The mechanism related to local anesthetics is a reversible inhibition of membrane sodium channels. This ultimately leads to failure of initiation and propagation of an action potential. We're talking about the analgesic effects related to these medications and much lower concentrations. We're looking at inhibition of sodium channels at the nerve fiber level. This ultimately leads to inhibition of pain and temperature sensations. However, in the setting of accidental intravascular administration, which will lead to much higher concentrations and toxic effects. We have inhibition of sodium channels within the central nervous system and the myocardium, which leads to neurotoxicity and cardiovascular toxicity. And talk about the effects related to anesthetics. We'll break this down into regional effects, spinal or epidural effects, systemic toxicity, again, in the setting of accidental intravenous injection, allergic reactions, and then methemoglobinemia. So related to regional effects, patients can suffer from prolonged anesthesia. They may report perioral paresthesias, slurred speech, facial droop, muscular twitching, tinnitus. It is very rare that patients will have permanent sensory or motor deficits. When a high spinal or epidural block is administered, and high spinal meaning high in the thoracic or C-spine, there can be impact on the parasympathetic nervous system. We can see bradycardia and hypotension, as well as respiratory distress and respiratory arrest if some of the cervical nerves are impacted. Systemic toxicity, again, in the setting of accidental intravascular injection. Patients will suffer near immediate seizures due to the lipophilicity of these medications. They quickly cross into the blood-brain barrier and block sodium channels, and then also dysrhythmias. We're talking about cardiotoxicity. On EKG, we may see wide QRS. We can see ventricular tachycardia, ventricular fibrillations, and patients may suffer cardiac arrest. It's important to note that bupivacaine is the most potent cardiotoxin of this class of medications. Allergic reactions are quite rare. They are IgE mediated, and this is really more common with the amino esters, and that's because when they're metabolized, they produce a known allergen called PABA. And then finally, methemoglobinemia, which is most commonly associated with benzocaine, prilocaine, lidocaine, and tetracaine. And it's really because these medications are metabolized to oxidizing agents that induce oxidative stress, subsequently converting hemoglobin into methemoglobinemia. This is a dose-dependent toxicity, and we see more commonly when these medications are administered along damaged mucosa that leads to a higher systemic circulation. We're talking about diagnosis. History is critical here. Specific levels can be obtained and are helpful if obtained early. So a lidocaine level that's greater than 6 to 10 milligrams per liter is considered a toxic dose. Additionally, a BMP and ABG with co-oximetry and ECG should be obtained. MAGAX is a metabolite of lidocaine and can also be obtained to confirm toxicity, though is likely of limited clinical utility in the acute setting. Management here is really focused on stabilization of toxicity. Decontamination is not administered because these are intravenous or intrathecal medications. So coma and seizure should be stabilized with airway management, and GABA agonists should be administered. Hypotension should be treated with fluid resuscitation, and dysrhythmics really should follow protocols outlined in ACLS. Oftentimes, the dysrhythmias associated with local anesthetics are very challenging to control, and some patients may wind up on ECMO. It's important to optimize myocardial performance by correcting any electrolyte disturbances, treating hypoxia, and correcting acidemia. The anecdote associated with local anesthetics is intravenous lipid emulsion. So this can be administered in a bolus of 20% lipid, which is administered first as 1.5 milligrams per kilo over 1 minute, and then as a continuous infusion of 0.25 milligrams per kilo per minute. If the arrest is persistent, the bolus can be repeated 1 to 2 times, and then the infusion rate can be doubled to 0.5 milligrams per kilogram per minute. And if ROSC is achieved, the lipid continuous infusion can be continued for an additional 10 minutes. Finally, we'll move on to methotrexate. So methotrexate, as we'll see, is a folate anti-metabolite agent, has a variety of indications. First, rheumatological instances, so psoriasis, rheumatoid arthritis, systemic sclerosis. We also see this used in OB-GYN, whether that's for placenta accreta or for ectopic pregnancy, and then also for a variety of oncological conditions. It's available in oral, intravenous, and intrathecal formulations. It's important to remember that the therapeutic concentrations when administered orally or intravenously do not penetrate the blood-brain barrier, just the intrathecal version does, as it is injected into that space. And we often see toxicity with the oral dosing, as patients will take this once per day instead of once per week. Methotrexate, again, works as an antifolate or a folic acid antagonist. So if we see folate here, it ultimately inhibits dihydrofolate reductase, which takes folate to its activated form as tetrahydrofolate. By inhibiting this enzyme, we do not have activation of folate. Subsequently, it cannot be used to make purines, which are the essential components of RNA and DNA synthesis. Toxicity is complex and is really dependent on both the route of administration and the chronicity of exposure. For single acute unintentional ingestions, there are often very few or no symptoms, and these are considered benign. It's important to note at therapeutic dosing, 25% of patients will experience bone marrow suppression. And then any oral dose that exceeds 1.5 grams is associated with significant toxicity. And again, this is often in the setting of when an oral dose is taken once per day instead of weekly. Toxicity is very severe when the intrathecal formulation is administered. Oftentimes, this is a dosing miscalculation, and if it exceeds 500 milligrams, we see severe morbidity and often death. Clinical manifestations are such that this affects multiple organ systems. So first, the gastrointestinal system is affected. Patients will complain of nausea, vomiting, diarrhea, and you'll find evidence of ulcerative stomatitis, so ulcers within the mouth and oropharynx, then detected on CBC in the subsequent days, leukopenia, anemia, thrombocytopenia. Any of these can be isolated, maybe a bicytopenia or pancytopenia can be identified. Patients then can suffer acute liver injury, and there have been some instances of progression to cirrhosis. Patients will suffer from encephalopathy, which is often multifocal, seizures, and coma. We see instances of interstitial pneumonitis, acute kidney injury due to acute tubular necrosis, toxic epidermal necrolysis, and Stevens-Johnson syndrome, erythema multiforme, and exfoliative dermatitis. And then often death is due to sepsis, and often this is due to gram-negative rod bacteremia due to translocation from the gut, and then multi-organ failure. It's important to note that this is a profound teratogen, and it's a Category X medication. Diagnosis, again, is based on history. We can obtain specific methotrexate levels, and a concentration greater than 1 micromole per liter is considered toxic. In the setting of toxicity, this should be monitored every 24 hours. We should also be obtaining a CBC to look at platelets, actually all cell lines, platelets, hemoglobin, and white cells, a CMP to evaluate for kidney function and liver function, and then chest X-ray in any patients who are hypoxic or complaining of dyspnea. Management first starts with decontamination, so activated charcoal can be administered in the acute setting, but is not helpful in the chronic setting due to high tissue concentrations. And then the majority of care is really focused on supportive care. So these patients get very, very sick. We need to stabilize shock. They often are hemorrhaging from their GI tract, and fluid should be administered. We have to maintain their oral airway. There's no true anecdote, but there are some other therapies that can be administered. So in the setting of pancytopenia, granulocyte colony stimulating factor can be administered. Leucovorin rescue, which leucovorin here is will activate this compound right here so that we do have synthesis of purines and ultimately production of RNA and DNA. Oftentimes in the setting of intrathecal oncological administration of methotrexate, leucovorin is empirically administered to patients to prevent toxicity. And then glucarbidase, which is a recombinant enzyme that hydrolyzes methotrexate and ultimately rapidly lowers concentrations so that it does not exert further toxicity, can be administered. Enhanced elimination, so hemodialysis can be utilized in order to clear methotrexate from compartments. And then we also utilize urinary alkalization with sodium bicarbonate to enhance elimination. For intrathecal overdoses, ultimately oncology really manages these, but we should be familiar with them. So the cerebral spinal fluid ultimately can be drained or exchanged. Patients may undergo ventriculolumbar perfusion, and then leucovorin at a very high concentration, as well as dexamethasone and glucarpidase can be administered. That's all I have. Thanks so much for listening.